Welcome to PFT Tutor with Jeffrey Haynes. In this video, we'll briefly review a case of a patient with a normal spirometry test that may not be so normal. This patient is a 41-year-old who started smoking young and smoked 3 packs a day for most of his adult life. However, he was able to cut down to 1 pack a day 5 years ago. So even though he's fairly young, he's already smoked roughly 562,000 cigarettes and has a chronic cough, so spirometry testing is clearly indicated. Here's his flow volume loop from spirometry testing. It appears to be a high quality test with no obvious abnormalities. His spirometry data is all normal with z-scores just under 0, and you can see on the graph that his values are above the lower limit of normal. However, this is not the patient's first spirometry test. I tested this patient a little less than 3 years ago, and what you see here is a 300 ml decline in FEV1. The normal decline in FEV1 associated aging is about 25 mLs per year. This patient's FEV1 is declining 100 mLs per year. If he continues on this trajectory, he will have lost 1,000 mLs from his FEV1 by the time he turns 51. For this reason, I would not consider this test normal. Sure, his values are in the normal range, but he has an accelerated loss of lung function that can't be considered normal. This is a trap that people can fall into when you're only looking at a single data point and declaring that there's no disease because the data is in the normal range. What you may not appreciate is that the patient is actually declining through the normal range. In this case, I think there's a reasonable chance that this patient actually has early COPD. The patient's first test is at the top of this slide, and the present test is at the bottom, and you can see that the FVC, FEV1, and FEV1 to FVC ratio are all shifting downward to the left. And some of you may be thinking, how can this patient have early COPD if the FEV1 to FVC ratio is so normal? He may be transitioning into a spirometry pattern called PRISM, which stands for Preserved Ratio Impaired Spirometry. And this is defined as an FEV1 less than 80% of predicted and an FEV1 to FVC ratio greater than 0.7. And some patients with PRISM go on to developing airflow obstruction and COPD. And patients with PRISM actually have worse outcomes than COPD Gold 1. As shown here from the Rotterdam study, in red, survival is worse if you have PRISM than if you have COPD Gold 1 or normal spirometry. Another important concept to keep in mind is that spirometry may not be as sensitive as other tests for detecting early COPD that starts in the small airways. In this study of smokers and non-smokers with normal spirometry, airway resistance measured with oscillometry was higher in smokers, shown in red, than non-smokers, shown in blue, even though both groups had normal spirometry. In this study of patients with respiratory symptoms but normal FVC and FEV1, oscillometry was able to detect small airways disease in around 61% of patients using the resistance at 5 Hz or R5, and 57% of patients at R5 minus R20, which is supposed to isolate the small airways. Compare that to spirometry, only detecting it in 20% of patients using measures of small airways disease such as FEF 2575. Key points: a normal test result doesn't mean that there is no lung pathology present. Pay close attention to longitudinal changes in lung function, as patients may be declining through the normal zone. Remember that COPD starts before age 40, so testing high-risk patients earlier rather than later is a wise thing to do, and it helps you build up some data points so you can see these longitudinal changes. And tests like oscillometry might be better at detecting small airways disease where COPD begins. Thank you for watching PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons, and we'll see you next time.